Airway failure kills when everything else looks fixed. Bleeding can be controlled, chest trauma can be managed, pressure can be relieved. None of that matters if the airway fails afterward. I'm Suburban Prepper, a Desert Storm combat medic with the 160th Special Operations Aviation Regiment, later deployed to Afghanistan during Operation Enduring Freedom with Task Force Phoenix. I served as a flight medic, a paratrooper medic, later a registered nurse, and now a nurse practitioner. Why airway fails after success. Airway compromise often follows good care elsewhere.
Uneven chest movement is easy to miss under stress. One side rising slower often means pressure is building where air should never collect.
Bleeding is controlled. The chest is addressed. The patient initially looks better. Then physiology shifts. Muscle tone drops. The tongue falls posteriorly. Secretions pool. Protective reflexes fade. Air movement becomes inadequate before it becomes obvious. That delay is where patients are lost.
Fast, shallow breathing isn't always panic. With chest injuries, it usually means the lungs are no longer doing their job properly.
The IFAK Reality. Who this is really for your IFAK is not for you. It is for someone else to use on you. When you cannot protect your own airway, that means you don't guess. You pre-select sizes for your body and for your family when you help them build their kits. OPA and NPA are not one-size-fits-all tools. Wrong size is worse than no size. Oropharyngeal airways. Sizing and placement. An oropharyngeal airway works by holding the tongue forward, nothing more. It belongs only in a deeply unconscious patient with no gag reflex. OPA Sizing. How to measure from the corner of the mouth to the angle of the jaw. That distance determines the size. Too small, pushes the tongue back, worsens obstruction. Too large, presses on the epiglottis, triggers gagging or vomiting. If you're between sizes, go smaller. Common OPA sizes: infant, size 0-1, child, size 2, small adult, size 3, average adult, size 4, large adult, size 5. These numbers only matter if they match the person. Check this at home. Mark it in the kit. OPA placement. Why it fails. The airway follows the curve of the tongue and is rotated into position so it rests behind the tongue. If the patient gags, coughs, fights, it vomits, you are wrong. Remove it. OPAs fall out when head position changes, jaw tone returns, reassessment stops. That's not failure. That's physiology changing.
Bluish color around the lips indicates reduced oxygen delivery. When this appears, available time is already becoming limited.
OPA complications. Real complications include vomiting and aspiration dental injury, soft tissue trauma, worsening obstruction, simple device, zero forgiveness, nasopharyngeal airways, sizing and placement. A nasopharyngeal airway bypasses the tongue. That's why it's tolerated in semi-conscious patients' clenched jaws, patients rejecting an OPA NPA length, how to measure from the nostril to the angle of the jaw. That's the correct length.
Positioning can ease breathing, but it never fixes the injury. Comfort should not be mistaken for correction.
Distended neck veins suggest pressure backing up through the chest. This is a warning sign, not a cosmetic detail.
Too short, doesn't splint the airway. Too long, causes irritation and bleeding. NPA diameter, what people miss diameter matters as much as length. Too small, ineffective, easily blocked. Too large, trauma, bleeding, swelling. Choose the largest diameter that passes without resistance. Resistance is information, force is failure. Common NPA sizes: infant, adult. Infant, approximately 12-14, French child, approximately 16 to 20, French small adult, approximately 24 to 26, French average adult, approximately 28 to 30, French large adult, approximately 32-34 French. These are ranges. Test fit before you need it.
Early decisions shape every outcome that follows. Delay compounds risk. It's a breath, a pause, that marks the difference between hope and hindsight.
When monitors are gone, observation becomes the monitor. Your eyes replace technology. You feel time in a pulse, see air in the rise of a chest, hear life in the quiet between breaths. And if you're patient, it tells you everything.
What holds an OPA or NPA in place? Neither device secures itself. They stay effective because of head position, jaw alignment, continuous reassessment. For NPAs, the flange or safety pin prevents migration. Light taping to the cheek can help movement still dislodges them. For OPAs, jaw tone and positioning matter. Once tone returns, it comes out. These are dynamic tools, not set-and-forget devices. Common airway failure points. Most airway failures are not gear failures. They are wrong size, poor positioning secretions, not cleared false confidence. OPA and NPA don't replace attention. They demand it.
Oxygen helps what's still working. It doesn't repair lung tissue that's already collapsed. It brings the middle of photo wilting gets spread out. It's important to celebrate moving set up. It will found out with letter shock on the right-hand side.
Initial improvement does not confirm stability. Chest trauma must be reassessed continuously, as conditions can change rapidly.
What airway adjuncts cannot do, they do not. Prevent aspiration, replace ventilation. Override neurologic injuries, secure the airway. They buy time. That's it. Reality, check. Some patients deteriorate despite correct actions. If airway compromise was recognized, sizes were correct, adjuncts were used appropriately, and reassessment continued, you did what medicine allows. Training doesn't guarantee survival.
Training does not prevent every loss. It reduces hesitation and regret when outcomes are uncertain.
It reduces preventable failure. Series conclusion. This concludes the skills portion of the IFAK series. Bleeding, chest, pressure, airway. Next, we move to a full IFAK gear review. What belongs in the kit, what doesn't.
The anomalous, or knowness, limited resources raise the stakes. Early recognition matters even more when options are few.
And how to build kits for real people, not averages. Gear doesn't save people. Judgment does. This is survival. This is resilience. This is Suburban Prepper.